Hey everyone, I had a great conversation today with Dr. Tania Dempsey. She's a medical doctor and she specializes in Lyme co-infections and also mast cell activation syndrome. She's been on the podcast in the past to discuss the mast cell, but I wanted to drill down today into Lyme and to co-infections because I have a growing suspicion, in part due to my own personal experience, that this may be something that flies under the radar for some people and is what's causing their fatigue, their insomnia, their brain fog, their joint or muscle pain, and perhaps even in some cases, some of their digestive symptoms like food reactivity. However, it's also something that can be kind of a wastebasket diagnosis where people are just offered this very vaguely, and it can be mishandled and miscommunicated, in my opinion, and lead to unnecessary fear and suffering. So the correct perspective, one that's open-minded but also a little bit circumspect, is what I feel Tania brings to this conversation, which is why I'm excited to share the discussion with you today. So with that, I'll now go to my discussion with Dr. Dempsey. Welcome to Dr. Ruscio Radio, providing practical, science-based insights into health. We break through the bias and the noise to bring you simple, trustworthy information that matters. Hey everyone, welcome back to the show. Today I have a special treat, Dr. Tania Dempsey, who, Tania, I really appreciate your work and your perspective. I'll, circle back to why in a moment, but welcome to the show.
Yeah,
welcome
that's
back to the
right.
show.
I was on a few years ago, I think. Happy to be back. Thank you.
It's good to have you back. And, obviously I knew of you through the MCAS community, Afrin, wine stock. I believe that was the main topic last time that we spoke was MCAS. And we just happened to be on a panel together in Austin maybe 2 months ago. And I got an even further chance to hear your perspectives, of which we had so much commonality in terms of let's not be heretical, let's not be fearful, let's be practical, being mindful to kind of the psychological impact that not feeling well can pose. And you really seem to integrate that into how you care for people. So I said, it would be good to circle back and talk about some of the other stuff that you focus on, which I think I've had a little bit of flirtation with, which is whatever label we want to use, Lyme disease, vector-borne illnesses. So here we are, and I'm excited to talk more about this.
Yeah, happy to dive right in.
There's a few different names, and some of these names I don't love because sometimes they carry a very extreme connotation. Lyme disease. Do you have Lyme disease? Do you not have Lyme disease? It's almost like this terminal prognosis or bleak prognosis, terminal condition. And I don't think that's true. And I believe you don't feel that it's true either. But maybe we start just for people who might be thinking that their joint pain, their brain fog, their insomnia, their fatigue could be caused by one of these microbes that can hang out in your blood amongst other places. So how do you think about these? And maybe just give us like the high level in terms of some of the common organisms, some of the labels that are used, and then we can start to get into the nitty gritty.
Yeah, probably my pet peeve is using the term Lyme disease. Some people say limes, and I'm just going to correct everybody. It's not limes, and most of what we're seeing isn't actually Lyme disease. And so I'm on a mission, along with some of my colleagues, to really try to specify what is really going on, because there are lots of infections that are transmitted by ticks, but also we call them vectors. They are different types of insects. They could be biting flies, ants, mosquitoes, lice. And the list goes on, right? So you can get infections from lots of different places, okay? And humans from the beginning of time have been exposed to many of these microbes in various ways. I mean, that's the thing. Like, we are in contact with our environment, right, all the time, and so the possibility of contracting an infectious disease in general is pretty high, right? Any infectious disease, you breathe, respiratory viruses, everything else, right? So I think about it as, I think the chances of being bitten by an vector is fairly high, right? Unless you never leave your home,
Yeah.
and even actually in your home, actually, right? If you have cats and the cats are carriers of, let's say, Bartonella, they can, if they scratch, they bite, they can transmit it. Bartonella we used to call cat scratch fever. We know it's much more than that. But the point is that it's just so easy, unfortunately, to acquire various infections. And so I think it's just important to think about, when we think about people who are sick, I think we need to put it on our differential. Could this be an infectious disease that they acquired in some way? And that's why, like, history taking is so important. You really need to go through the history from birth, even before birth, because there's a possibility of contracting infection in utero. So the mother carries it, then the baby can get it, and then you live with it for the rest of your life. It could be things you've been exposed to over the course of your lifetime. So we try to identify that and try to really understand, okay, is this potentially a problem, right? So I always think about in my patients infectious diseases. There are lots of other things to think about, when people are sick, but if we're talking about infection, I like to call it vector-borne infection because these are vectors that are transmitting it. And under that category, I mentioned Bartonella. That is a big one. That's a big one that's very insidious. It's found everywhere in this world, in sub-Saharan desert, it is the most pervasive probably of the infections that we see. There's a lot of arguments about Lyme disease. Lyme is a vector-borne infection. There are lots of different strains of Lyme. There are some strains of Lyme that are found in other parts of the world, but the traditional Lyme disease, Borrelia burgdorferi, may really not be found in certain places in this world, but the cousins to it are found pretty much everywhere. But we have a huge problem with testing and figuring that out. We have another infection that often goes along with these is Babesia. So Bartonella and Lyme are bacteria. Babesia is a parasite. It's a blood parasite. And it invades red blood cells. It's a very similar cousin to malaria. Malaria is a vector-borne infection. You get bitten by a mosquito that carries malaria, you get sick. Babesia is a cousin. It has some similar features to it, but it often actually lives together with Bartonella in the red blood cells. That's one of the places where Bartonella goes. And so they often cohabitate.
Right.
And cause problems. And there are many other vector-borne infections: ehrlichiosis, tularemia, brucella, tick-borne relapsing fever, Borrelias, and the list goes. I mean, I could just sit here and just list them, right? So there's lots of them, and the challenge really is identifying it. We still don't have the best tests. We have some that are getting better. There's no question, but we just don't. It's very hard to identify all that. So that's a brief overview.
If this has been helpful, please subscribe, comment, and if you wouldn't mind, share this with one person you think it might help. And there's a few threads there that you mentioned that I think are really important, which is many of these microbes, maybe you could argue most, are fairly ubiquitous. Like you said, cats, fleas, ticks, lice. To approach this from the perspective of either you have Lyme or you don't, I think it's a very pathological and it's a very psychologically disserving and disempowering perspective. Are you branded with the mark or the thing, or are you not? And that's why I want to start with sort of reframing this as almost like Epstein-Barr virus or even shingles and chickenpox. These are things that most of us have probably been exposed to, but the bigger issue is the host immune system strong enough to be able to coexist and police these things. And so it's more about the terrain and the host than it is the microbe. And there might be some exceptions to that, but I think the exceptions are truly the exceptions, and the rule should be, what can we do to modulate the health of the host?
I couldn't agree more. Because the reality is that, if I go outside, I mean, I'm in, a part of New York where it's endemic. A lot of this stuff is endemic, including Lyme disease. But if I pull 100 people into my office off the street and I start testing them, I'm going to find a lot of Lyme disease. I'm going to find a lot of Bartonella. I'm going to find Babesia. I'm going to find Ehrlichiosis and Anaplasma. But not all those people are sick. They might have some, I will argue, will have some chronic issues that no one's ever looked at, right? And we can attribute it maybe to infection. But there are also people who are their immune system is just able to handle it better. And the reason I think that some people get sick is there's an immune dysregulation that is occurring, and that's caused by lots of different things, which we can talk about. But yes, we are the host, and if we can't deal with those infections, we're gonna get sick.
Right. And is it fair to say that you feel there might be, in some cases, an event that weakens the immune system enough for the microbe to establish a foothold, and it might just be giving the system some assistance so that it can get a leg up, and then from there the system can probably self-suppress or regulate, and there's not this need for ongoing care. I mean, with maybe an exception that if someone's chronically not sleeping enough, then there may not have been an event like an acute stressor that weakened the immune system. So sometimes it's obvious lifestyle stuff, perhaps. But is that sort of a fair general way to paint this?
I think that, I guess, because my lens is with mast cells also, right? I have this lens, infectious disease and mast cells.
Sure.
I think about a lot of things through that lens. And so, I think that many people are born with, let's say, a vulnerability in their immune system. And as humans, we all have some vulnerability in terms of
some weak link in
right?
the armor,
And,
sure.
I think some people are maybe even more susceptible. Maybe it's the stress of their birth. Maybe it's the stress of the family that they lived with, some kind of trauma, accident, something. It could be something early on in life. It could be something later in life. It could be an escalation of things that over the course of a lifetime has occurred. That changes the nervous system, and it changes the immune system. And now that immune system can't handle things the same way, and is now going to react in a way that, sort of thinking that everything is bad. It's going to start fighting, but it's going to fight inappropriately. Right. And that's where mast cell activation syndrome comes in. Right. So what I would say is that for a fair number of patients, if we can figure out the traumas, help them deal with that, heal them, get their mast cells a little bit happier, figure out the key to that. Maybe it's from a limbic system approach. Maybe it's from a vagal nerve approach. Maybe they're living in a moldy home. There's so many layers and layers and layers. So I always use this analogy of the onion. We're peeling and we're peeling away. Then maybe that Lyme disease that's there, the Bartonella that's there, can be dealt with more easily. Or sometimes maybe not even, right. Like it's sort of like they go into hiding and we're okay. But, sometimes that's just not, it's everything we do is not working. And it's because these infections, particularly Bartonella, it's a stealth infection. It is going to figure out a way to elude your, or hide from your immune system. And so even if your immune system is great, you may not be able to get it. And then insidiously, it's sitting there and multiplying, invading into different tissue and organs, and maybe sometimes it's just not going to be possible, right? So it's important, and I do this all the time with my patients, and really trying to figure out how much of it is that I have to kill the bugs, and how much of it is that I have to support their immune system so they can kill the bugs.
Yeah, and I'm assuming the optimum approach is going to be a combination of the two.
Usually.
Right.
Usually.
Without, you can do a lot of killing, but if you're not addressing what's suppressing the immune system, then the killing's probably going to be insufficient long term. I want to tie in the symptoms for people. Some of these are, in many syndromes and conditions, the challenge is the symptoms are quite nonspecific, but there's at least one partially validated questionnaire. A few things I'll throw out there and definitely want to get your thoughts. Fatigue, although fatigue is not very specific. But when you see fatigue and joint pain and brain fog, and the way I've been thinking about this more recently, we were able to find a paper that also commented on this. If you're seeing more than 3 non-digestive symptoms, that can sort of start to give you a hint, because obviously in our clinic, we will see a lot of abdominal pain, diarrhea, constipation, bloating, plus insomnia, brain fog, joint pain. So, okay, there we're thinking, let's look at the gut first and reevaluate. But if someone either after improving their gut health, so the gut symptoms are all or mostly gone, or they just at baseline present with a bunch of non-digestive symptoms, this starts painting at least a suggestion that there could be some sort of vector-borne illness present. That's a really broad brush, but I would love to hear what symptoms or sort of presentation in particular starts to cue you in that there might be something with a vector-borne microbe present.
There are quite a few things. The things that the patients come to us here, really, very, very commonly for diagnosis and management of mast cell activation syndrome. So many of them, some of them know that they've had a tick bite. Some of them know that but they've been told they're fine. That's not the problem. The problem is, their immune system, and they want to address it. And so we start to, let's say we diagnose them, but they don't respond to treatment. We are working on, Dr. Afrin may not have the functional medicine approach, but everybody else here is sort of looking at it from a functional medicine perspective. We are looking at their gut, and we're looking at their stress and their sleep and their food and all that stuff. And they're not, and we're targeting their mast cells, in a very systematic, methodical way, and they're not responding, right? I'm going to start thinking about, I've already thought about it before, but, especially in patients who, let's say, are coming to us who already have started treatment and they're not getting better, you have to start thinking about, what are you missing? What triggers are you missing? And one of the triggers is infection. And so that's why I have to consider that. I think that people who have symptoms that wax and wane, that sort of travel all over the body, that's always a little bit of a red flag that there may be something else. Mast cells can do that, but there's usually something causing the mast cells to do it. So mold and infection are like the two big ones that I'm always thinking about, and even mold internally. So like yeast and candida is a huge issue for a lot of patients. And sometimes it's like the combination of all. So fatigue is such a general symptom, and I've certainly helped people with fatigue who we address their microbiome, or we address some other issue. It's not always vector-borne, but again, persistent symptoms that are also associated with migrating joint pain, migrating maybe neurologic symptoms. Neurologic symptoms are always a little bit of a clue. Acute presentations of anxiety, depression, OCD, always on my radar that there may be something that's driving the mast cells to do that. So I think mast cells are actually the part of the cause of those symptoms, but I have to look at what is causing the mast cells to become dysfunctional. And so I'm going to, look at those things.
Right.
So I can't say there's one, specific symptom, because they're all different. These infections are different. Bartonella patients often present with, there's some classic symptoms, and then I've seen, things that I would never have realized. But, they sometimes have feet pain. They sometimes have sort of the bottom of the feet. They sometimes have stretch marks. They sometimes have difficulty losing weight. They gain weight very, very quickly. They have a lot of neuropsychiatric symptoms. Sometimes it's just anxiety. Sometimes it's mixed with some of the other things. That's going to kind of clue me in a little bit. Like, okay, I know mast cells are here, and I'm gonna look for that. But Bartonella has got to be. We gotta rule that out or rule it in, and figure out how we're going to address it. So there's some things that a little bit have that like flavor that helps me, determine, okay, this is the direction.
Right.
But I have a skewed view of the world because of where I'm practicing, and also the patients that come to me.
Sure.
So, what I did a retrospective look at my chart review, and I presented it at ILADS, I think last year and the year before. ILADS is the International Lyme and Associated Diseases Society. I'm now on the board, and I presented basically a chart review to look at my numbers, like how many patients have mast cell activation syndrome, how many patients also have Lyme or Bartonella or Babesia. And it was like 90% of my mast cell patients also had a vector-borne infection. So that's a
Yeah.
huge
Yeah.
number.
And it's saying a lot with the fickleness of diagnosis. Was this all based upon laboratory diagnosis, or was it a clinical diagnosis?
All
Based upon symptoms? Was it a
all
marriage of the two?
I needed to prove that they had laboratory evidence.
Right.
So this was
Okay.
laboratory proven. Now, again, not all of those patients are going to require antimicrobials, antibiotics, but a fair number will. Again, I'm really trying to peel that onion away, and everybody's onion is different. The layers are different, and they're in different places. And for some, the Bartonella is the top layer, and it doesn't matter what I do with anything else. I've got to deal with that first. And sometimes it's much deeper, and I won't get to it until I, do the rest of the work. So it's complicated.
Sure. I think Bartonella has been something that I've had a little bit of a dance with, and I'll tie some of that in here throughout our conversation. But regarding questionnaires, we looked into this, and there's the Horowitz questionnaire, which at least seems to have one study validating it. I mean, published by the author. So it's something, it's great. I would love to see it validated by others, but this area is an area where I think the research is really in its nascency. And for our audience, I know that I try to always bring to the show a very evidence-guided perspective. And in GI, we have that luxury. I mean, look at all of the meta-analyses we've talked about regarding probiotics and low FODMAP dieting. In this area, there's much sparser data. So I think it's really where we have to look at clinicians in the trenches and use our best judgment. Unless, Tania, I've missed a whole boatload of research, but it seems like there's just not a ton to pull from. So maybe the Horowitz questionnaire is one of the best subjective assessments that we have.
And right now there is a real push for more research, and many of us who are really involved in this field are trying to figure out ways to do that research so we can. I'm a big believer in evidence-based medicine for sure. I come from a very traditional allopathic background, so I still have to maintain that. But at the same time, I have to look at the patient in front of me. And sometimes I don't have the evidence that I want, but I have some, and I have the evidence I have from the patient. And so sometimes there is a little bit of a compromise because the reality is that with evidence-based medicine, sometimes even though I'm a big believer in it, sometimes it really clouds judgment. And so there's a little bit of there are lots of quote unquote evidence-based research out there from doctors who are really sort of discounting patients' symptoms and are telling them they don't have Lyme disease or they don't have these infections, that it's impossible based on their criteria. Their criteria is faulty too. How did they validate their criteria? Some of that criteria is 30 years old. In the Lyme disease world, like Lyme disease specifically, there's this sort of push to move away from this, but people are still using it. It's 30 years old. The ELISA test, you have to do an ELISA screening test. That's first. You can't just do a Western blot. You only do the Western blot if you have a positive ELISA. And so the problem is that there are doctors who have evidence in the literature, but it's biased.
And do you think some of that just comes from the fact that there's generally a paucity of data here? When we look at that as compared to maybe IBS, I mean, look at all the research on IBS. It's such a research condition. I would think that with volume of research literature, you'd progressively sort of weed out bias with larger sampling and more rigor. I don't know this for a fact, though. I haven't dug deeply enough into the Lyme literature to see how robust is the research? Do you think a paucity of research is part of the problem, or where do you think the problem
part of
comes
it.
from?
I think the issue really is that as we said earlier, we're talking about vector-borne infections, and there are hundreds, if not thousands, really, of possible infections. We talk about a handful commonly, but I always think about the fact that we may be missing something we just don't have the testing for. We haven't discovered it yet. We're always learning about these new emerging infections, right? COVID was an emerging infection. So first off, I don't think we know what we don't know. We don't have the testing, that we need. I think that testing in the infectious disease realm has been fraught with sort of difficulties because a lot of it was relying on antibody tests, and we should talk about the problem with antibody testing. Then there was sort of a reliance on PCR testing. There's a problem with PCR testing. Now there's sort of an emergence of fish testing, fluorescent in situ hybridization testing, which may be better. So there is a evolution here. We are developing better and better things, but traditionally speaking, infectious disease specialists always relied on antibodies and PCR. And when we talk about the vector-borne infections, we're talking about Lyme disease, Bartonella, Babesia. Antibody testing is really inconclusive very often, and there are lots of reasons for that. And we again, I do want to talk about antibodies. PCR sometimes doesn't pick it up for lots of reasons. Okay, depending on where the infection is hiding, you do a blood test. Maybe it's not in the blood at the time. Again, PCR has its flaws, and so there are lots of people who have these infections. We haven't found them, and so a lot of the literature is based on when people meet the exact criteria, which I just said is really faulty.
And is it fair to say that the criteria oftentimes is more so suited for an acute presentation, shortly after a tick bite with a bullseye rash and very sort of obvious symptoms? Because it would seem that would be the time most research would be done, is the acute presentation. But perhaps, I think as you're partially alluding to, when things become more chronic, that's when the testing that's used in validating the acute presentation may not have the same level of accuracy.
Now, in the acute presentation of, again, if we're just talking about Lyme disease, the blood testing will be negative for at least a month after an infection. So people are you either need a bullseye rash to make the diagnosis, or you have to have a strong clinical suspicion. But that's the problem.
Right.
So some people, they get bitten by a tick, then they say, I'm going to go to my doctor and get tested. The testing is negative. The doctor says you don't have Lyme. Well, I don't know that yet because it could still be simmering under the surface. We don't know. So there's a lot of problems even with the acute stuff. But yeah, generally speaking, in the more chronic phase, a lot of these infections have an immunosuppressive effect on is part of the immune system. So it's stimulating the mast cells inappropriately. And so that part of the immune system is overactive. And then it's suppressing antibody production on the other end of things. And so you can do a Bartonella test and a Lyme test, and the antibodies may be negative. And so again, they must not have it because they don't have antibodies. They would have had antibodies if they were exposed to the infection. But the infection has affected the way their body is responding. And so sometimes when you actually treat the infection, and we see this actually very often in Bartonella, you actually treat the infection and then you do the antibody testing, and then, there are the antibodies because the immune system went back online. Now, there's another side of this that I want to mention, and that is that some patients have a lot of antibodies. They have antibodies to Lyme. They have all these bands that light up positive. They have, you test them and they test like for everything. And so the question is, do they really have everything, or is that really a problem with their immune system? And for some of those patients, what we know, and we published this, Dr. Afrin, myself, and a colleague in Germany, Gerd Molderings, just published a paper looking at it, basically titled Learned Cautions in Using Antibodies in Mast Cell Activation Syndrome, because mast cells can't talk to those other cells that produce antibodies, the lymphocytes, and can send a signal, make Lyme antibodies, make Bartonella antibodies. And so in some mast cell patients, what you get is spurious production of antibodies. Some of them are mimicking, some of them are false. And so in some cases, I can't look at that antibody testing actually as a representation of infection. I have to look at it as a representation of their altered immune system.
And this is where I think the PCR, at least philosophically, has merit, because it amplifies and allows you to detect minute components. But your claim is that even with the amplification that we get from the PCR, it can still miss.
Yeah, and again, I'm not a researcher, and I don't want to, kind of go get in the weeds a little bit here on how PCR is done, but we see this over and over and over again that the PCRs are negative, but other molecular tests might be positive. So, like a FISH test, which will rely on, let's say they use a probe. So the difference is like PCR is, they're looking for that DNA, and you have to find the DNA, and then if you don't, it's negative. So with a FISH test, they use a probe, and often, let's say for Bartonella, they may use a ribosomal RNA probe that should match the Bartonella, basically DNA or messenger RNA or some other molecule that should fit together. Okay, so they use this probe that's labeled and it has a fluorescent stain. And so if there is Bartonella around and they basically come together as a pair, it will light up, and you'll see a signal that there's something there. I think that's a little bit better.
Right.
I think it probably still needs a little bit more validation. I think that we still probably need even better testing than that. I'd love it to be even more exact, but at least in that case, you have a higher likelihood of finding it because you have this probe that's matching
Right.
specifically to the species that you're looking for.
One of the devil's advocate positions I've heard here by someone who's in the Lyme community themselves, I think it's mainly Bill Rawls who's voiced this, and there might be others, but I think I first heard it from him, is that there could be incentives amongst the new Lyme labs to find positives, and perhaps it's coming at the expense of producing false positives. Do you think that's an issue?
I've not seen that, to be honest. We get enough negatives that makes me feel like, again, not everyone is positive.
Right. That's fair.
We have done multiple labs sometimes. Some labs, there are a couple labs that have that capability to do FISH testing, and sometimes we'll get positives on both or negatives on both. So I feel like, okay, you have some kind of validation.
Okay.
I understand his perspective. I'm not seeing that. I think that the people in this field who really want to understand this, the leaders in the testing world, they don't want everyone to be positive, right? That actually kind of they lose their credibility if that's the case. But on the other side, I think the reality is that a lot of people have these infections. And so we are in danger of diagnosing a lot of people because, unfortunately, a lot of people are infected as well. But again, whether that infection is truly causing their disease is a little more difficult to determine.
Right. Yeah. And this is where I think the clinician interpreting the labs is going to be hugely important. Are there certain companies in particular that you like for testing?
I do use T-Lab, which is the FISH test that I mentioned. It's Dr. Mosiani's lab. I use IGeneX. There are some others that I think are not as robust, but I may use them for various reasons. Sometimes cost is an issue. But those are probably the two main ones. And I'm always looking and I'm always evaluating other labs. And I have patients who ask me all the time, can we look at that lab or that lab? And sometimes we try it, but I have to use the labs that I feel most comfortable with, that are giving me the information that I'm looking for. I either want to rule this out and I don't want to worry about it, or I want to rule it in so I can help the patient. And again, my clinical suspicion, if you have a high clinical suspicion, and I think this is really important, and I understand where Bill Rawls is coming from, but if patients have symptoms that are, and they're not responding to other treatment, and their symptoms are suspicious for a particular, let's just take Babesia, for instance. There's a flavor of Babesia patients. I'm not saying all of them are the same, but generally there is a lot of this waxing and waning. There's heat intolerance. There's or sweating, resembles malaria in a way. There's palpitations. There's anxiety. There's some neuropathy. There's other things. But like if I have somebody who has some of this stuff, and I do a Babesia test and it's negative, I might say, okay, you know what? It's negative now. I don't know if that's true or not. Let's leave that alone for now. Let's deal with everything else. Patient's still not getting better. I got to do the Babesia test again, Oh, it's positive. I knew it was positive. Why was it negative the first time? Maybe it wasn't in the bloodstream in the way that it would be easily detected. There's so
Right.
many issues. But the point is that you have to use your
Sure.
clinical judgment combined with the
Right.
labs.
Yeah. And I think the point you made about flavor is really important. As it pertains to Babesia, I've been looking at, are there aberrancies with their red blood cells? Is maybe hematocrit or
Yes.
hemoglobin low? Is it a non-menopausal woman who's waking up hot? Right. And so this is something that or a man who's, having hot flashes for no reason that we can determine. And there's some fatigue and maybe there's some brain fog. So you start looking at all these different data points and creating a mosaic of, well, this to me sounds like it could be Babesia. And one of the things that I've become concerned about, and I've voiced this on the podcast many times, is that with the wide availability of lab testing, some clinicians are losing their clinical discretion skills, like you're notating, and they're relying just on labs. And I think this does more harm than good. We've really got to be listening intently to the person and trying to compile that picture of what it could be.
And you really have to choose your tests appropriately. And I think that's the problem. That's one of the issues I have in the functional medicine world. I mean, I'm in the functional medicine world, and so are you, right? But a lot of practitioners, they go through the training. I'm sorry, I have to say this. I can't keep my mouth shut because really they go through this training. They learn about all the tests that they can do, and then they start seeing patients. They want to help. Their intention is good. This is not about intention, right? This is that
Yeah.
they have the patient in front of them. They just learned about the heavy metal test and the saliva test, and right, they learned,
And they
right?
use all
And
of
all of a
them.
sudden, and by the time the patient comes to me, they've done all these things. Now, I can say that, I use those tests too? Of course I do, but I have to also think about the patient and what is going to be the highest yield initially. And maybe over time, as I start to not really, maybe things don't make sense, maybe I then add the next test and I do the next test. But a lot of these patients, they get all this testing done. And then all of a sudden, they're given all these diagnoses. They have adrenal fatigue, they have, dysbiosis, they have SIBO. And all of a sudden, now they've
Yeah.
acquired all these problems that are hard to solve, right? They're not easy to solve. They can be solved, right? But they're harder and they take time. And now it's, does the patient really have those things? Yes, they do, I'm sure. But again, why? It's always to me like, well, why? That's the question I ask all the time.
Yeah. Are you diagnosing the cause or an intermediary mechanism?
Correct.
And also, I'm sure you see this. I mean, I've had patients literally cry when I told them, I don't really think the MTHFR, hetero or homozygous, means anything. I had one gentleman maybe 2 months ago. He literally started crying, and I'm thinking to myself, did I say something? And he said, "No, doc. Like I've just been so worried for the past year that I was just ticking time bomb, and to have someone just tell me that was all bunk. It felt like bunk to me. I didn't feel like I was that sick. I didn't feel like I had to turn my life upside down because of the mother effer gene my clinician told me is going to change how I have to live the rest of my life." And he started crying because of the year of fear that he was burdened with. And things like that's why I'm so passionate on the podcast, and this is why I love where we connect, because I don't think clinicians are realizing the weight of their words and the weight of the high or low on the lab tests that these patients are being confronted with.
Exactly, right. And you have to balance all that when you're treating patients. Yeah. I think we definitely have the same approach, so.
And again, we're also on the same page with in the functional medicine community. We're all on the same team. I just think the field's going through some growing pains where we have all this freedom of lab testing, and now we're learning how to use that freedom most effectively.
Yeah, agreed.
But this brings up another perspective I wanted to touch on, which is how important is it to know the specific microbe that someone has? When I look at, especially with the herbals, it's truly amazing how these herbals, like artemisinin, let's say, is antibacterial, antiviral, antiprotozoal, antiparasitic, anti-inflammatory. So I think one could make a case that you could go quite far with just looking at the person, having a clinical suspicion, and then if you're using herbal medicines, because so many of them will treat Babesia, Borrelia, Ehrlichia, whatever it may be, we may not need to get down to that nth degree of saying it's specifically this microbe. Plus, some have theorized that for many people, it's not just one. It could be a couple at the same time. But you have far more experience here with getting into the nitty-gritty. So, where do you draw that balance, and how much do we need that definitive identification of the one microbe?
Yeah, it's a good question. I am, again, coming from a more, I guess, evidence-based sort of background and allopathic medicine. So I still feel very, very strongly that we should be able to identify, diagnose the patients, and give them some definitive data. So it's the same thing. I get this question asked a lot about mast cell activation syndrome. How important it is to diagnose mast cell activation syndrome, because there are lots of treatments out there that you can use that are, really, safe and not harmful. And yeah, so
Natural.
do you really need the diagnosis? And so I kind of feel like you do, because it does make it easier to start to focus your treatment. It gives you more freedom to explore things that you might not if you didn't know what they really had. The same is true for the infection. So, listen, it's really rare that anyone has only one infection. That's the truth. I haven't seen a pure Lyme patient with nothing else in 10 years, probably. And probably when I saw it was only Lyme, it probably wasn't, but the testing wasn't, accurate. So they go together, vectors are carrying these infections together. So the reality is there are lots of infections. I can't test for all infections, but I can try to get the main ones, at least to understand. Now, sometimes patients are negative, but I still have a high index of suspicion. So as long as I've tried to diagnose them, then I can start treatment. If I'm going to go the herbal route, and I love herbs, you're right, it doesn't matter which exact one. Although, I might use Artemisia more if there's a parasitic type infection like Babesia. But Artemisia definitely has antibacterial and other properties. But it's my go-to more if I think there's a Babesia component. So there's some herbs that I can maybe target better, certain infections. And then you're right. Then there's the broad spectrum herbs that you're just going to use it and hope you get a lot of the other stuff that they're dealing with. But if I'm going to go beyond herbs and I'm going to think about antibiotics, which I use much less antibiotics than I have in my entire career. I really try to stay away from it at all costs, but there are times when it is unavoidable. I know that the infection is raging. I can't get it any other way. When if you're going to use antibiotics, you really want to identify the bug. Like that just doesn't sound right to me if you don't really have.
No, sorry, is that because the antibiotics are more narrow in the organisms that they treat? Or is it similar in that many get doxycycline, let's say? Is that something that will hit multiple microbes, or is it more specific to Bartonella?
It's more specific for Lyme, actually, and there is some research showing that doxy plus rifampin, like way back, was active against Bartonella. Now it seems like doxy is not that effective against Bartonella, so there's a lot of resistance that's developed. So yeah, doxy might be something I go to if I really think Lyme. Doesn't have a lot of Babesia coverage, although there may be a little bit. But doxy definitely is going to be better for Lyme. The macrolides like azithromycin, clarithromycin may be better for Bartonella, but there's still a lot of resistance, and it needs to be combined with other things like methylene blue or rifampin or other things. So and always combined with herbs, in my opinion. Like I really love to add in biofilm busters and other things. We didn't talk about biofilm. Biofilm is a big issue for these patients. So I guess my point is, and I have other treatments that I do. And one of the treatments that I use a lot right now is SOT therapy, which is, I don't know if you're familiar.
No, actually, I don't. I've heard of it, but I don't know much of anything about it.
So supportive oligonucleotide technique was developed actually in the cancer world. And it's being researched all over the country, all over the world, as a way of targeting cancer. In the cancer world, what they found was, if they could find the DNA, the mutated DNA from the cancer cell, and they could target it with a protein that matched that DNA, they would be able to shut down the cancer, and then the cancer would stop growing, right? So in the cancer world, it's called antisense therapy. There's a lab in Greece that we use that has developed this technique for infection. And so they are a cancer lab. I think that's how they started it. But then they sort of evolved and realized that the same technology can be used to target infection. So if you have a Bartonella bacteria and you have a particular strain, so this is why it's important to test. You can't do the testing if you can't do the treatment if you don't know what strain you have. So let's say you've identified it's Bartonella hensleyi, or it's Bartonella vinsoni, or Elizabethae, or Quintana. There are lots of there's actually I think it's almost close to 50 strains of Bartonella that we have really in this world. So we can only test a handful. But let's say we've identified it's Bartonella hensleyi. We can send the blood once we've identified it. We can send the blood to this lab. They can create a oligonucleotide, essentially a little like RNA molecule that matches the DNA of that Bartonella hensleyi. And when we infuse it, it basically gets into the system, gets into the cells, and then gets into the Bartonella cells and shuts it down and stops the multiplication and replication of the infection. And this has been a real game changer in my practice. I'm not saying it's curing. We don't know if anything cures these infections. They can hide for many, many years. But it's been amazing to use because for some patients who are really sensitive and they can't tolerate herbs and they can't tolerate antibiotics, I can use this molecule and target their infections directly. And again, if I know which infections they have,
Right.
I can do that.
So this makes me think about something that would be broader in its antimicrobial capability and wouldn't go through the gut and potentially pose reactions like you're suggesting. And two that have come across my radar screen of late are hyperbaric oxygen and then IV ozone. These both seem to have a lot of promise, but I'm just wondering what your experience with either one
We
of these
do
has been.
ozone in the office, and we do both ozone combined with like a UV light, and we do hyperbaric ozone or 10-pass ozone. So we don't do hyperbaric oxygen, but we do hyperbaric ozone. And yes, it's an amazing tool for patients with infection because it's antimicrobial, broad spectrum antimicrobial. It kills. It's a disinfectant. Ozone is a disinfectant. It's a super oxygen molecule, basically. Um, and it also can help sort of basically regenerate or refresh your cells, right? So a lot of times when you're chronically ill, especially with these infections, you're not oxygenating your tissues. That could be because of biofilms. That could be because there's an issue with the integrity of the vasculature carrying the oxygen through the body. We know that tissue doesn't get perfused the way we think it should. Not based on traditional medicine where they put a pulse ox on you and you're 99% and you're fine. I'm talking about at a cellular level, right? At a microcirculation.
Microcirculation?
Yeah. Which is affected a lot by these infections and in general, and chronic illness, COVID, and lots of other things. So ozone really can help that microcirculation, but also can also kill. And so and sometimes combining that with this SOT therapy is a really nice tool. Now, I don't do hyperbaric oxygen here in my practice, but I have patients who have done it. And it's a little bit mixed in terms of results. So, interestingly, and this is totally anecdotal, if the patient has babesia, they seem to do very poorly with hyperbaric oxygen. And I don't know if it's a herx that they're experiencing because babesia is in the red blood cells and is affecting oxygen, and maybe you're trying to push that oxygen in, and maybe it's a herx reaction. But in general, some of my babesia patients have not been able to tolerate hyperbaric oxygen. But generally, I think it might be a good tool for the right patient.
And is there a certain time course? I say this because I actually have hyperbaric here, and I've done a little bit of experimentation. But over the past about year, my health's had some ups and downs. So as I've been reducing variables, that was one of the things I wanted to wait on that and focus on other therapeutics that I knew would have better evidence, I suppose, amongst other things. Are you noticing a certain time to response when people do respond positively to the hyperbaric?
Yeah, and again, because I don't do a lot of hyperbaric, I don't do hyperbaric at all, and I just anecdotally from patients,
Sure.
it's hard to know. I basically none of my patients have had any really appreciable success with hyperbaric oxygen. Again, whether that's they didn't do it for long enough, the settings, there's so many variables because they were going to other places for it. I don't know.
Or selection, right? You're probably selecting for people who've not responded well to prior
Absolutely,
therapies.
absolutely. But on the other hand, some of these patients do ozone therapy, and I can't say everyone responds to ozone therapy, but a fair number will respond even within 1 or 2 treatments. It's very, very subtle. We had a patient here earlier who, yesterday actually, who has severe nausea, abdominal pain, has lost a lot of weight, anxiety, depression, of course, tested positive, fish positive for Lyme and Bartonella. And we started some, sort of gentle ozone therapy with the UV light. And after the first treatment, he ate like like a whole meal, like for the first time in many months. And so he was just so thrilled to be able to see, oh, wait a second, I think we're on the right track now. Like this is going to help. And that lasted a day or two. Then he came in for another ozone. And then almost immediately after the ozone, he's like, oh my God, I'm hungry. I'm going to go have lunch. Sometimes it's like that dramatic and you can see, the bugs are being killed, the body's getting oxygenated and ozonated and there's a response. And so others, there may not be for various reasons, with every treatment, right? Not everything works for everything.
Any experience with rectal ozone? I've seen this pop up also as something that's going to be a little bit less invasive. And some people I've even heard of are doing it at home.
Yeah, we've had some patients do that. And we also do, nasal ozone, especially if they have overgrowth. It could be mark-ons, could be sinus infections, fungal stuff. So that way, rectally, if they have gut issues, it's been mixed. Sometimes, interestingly, if there's a lot of inflammation, the rectal ozone can be a little bit irritating until the patient gets used to it. But for some patients who don't want to get the IVs or can't, they don't have access, getting ozone in other places, other orifices, sometimes, rinsing with ozonated water if they have a lot of dental stuff or mouth issues, ulcers. I might have them rinse with ozonated water. So there are like ways to do it. Again, it's not for everybody, but when it works, it's really nice.
And I guess while we're on this sort of category of HBOT, ozone, IVs, vitamin IVs, I believe this is something that you've used and you're seeing success with. So just curious, sort of anything in particular? I'm assuming a high dose vitamin C, as long as someone is G6PD negative, maybe a Myers cocktail. But yeah, what might people want to think about if they're going to go do ozone IV? And I say this under the perspective of seeing, at least here in Austin, how many IV clinics are just popping up where you can go in and get whatever you want, which, okay, I think it's good for people to have access, but I just worry that people may not have guidelines for how to use IV therapy.
Yeah, I worry about that too, because when patients come to us, let's say they really are just interested in the IV, we still have a screening process. You still have to meet with my PA. You still have to get some blood work done. We'll want to check.
Right.
I don't know what kind of screening is done in these fly-by-night operations sort of. I mean, I don't want to, minimize it, but it's a little bit like, they put a shingle up and they start doing stuff. I also don't know where they're getting their products from, because right now, all the ingredients are very expensive. Like if you're going to get quality, very often compounded ingredients, ascorbic acid, for instance, we want ascorbic acid that is corn-free. We only want it with cassava, made out of a cassava. Very expensive to get these ingredients. So for those clinics out there, if they're charging less because they're getting inferior quality products. So I worry about where they're getting their stuff from. I know where I'm getting my stuff from, and we're sourcing it, from the very best. So I think that's just important for people to know. Like you should ask. The other day, a patient said to me, "Oh, I'm just going to this clinic for my B12 shots, but they put some other things in the B12 shot." Well, what did they put in there? Oh, I don't know. I have to find out. But they did say there were other ingredients in there. Well, you better find out what else is going in there in your body, because I don't know what, how they compounded it and what, whether those other ingredients are good or bad or you're going to react to. So those are always things, to consider. We do vitamins, we do, and I mentioned ozone, but we do phosphatidylcholine, PC infusions. We'll do. I'm missing something. We'll do high-dose
High-dose
vitamin
vitamin
C
C,
for sure. We use that a lot. We do NAD, yeah,
NAD,
glutathione, right?
glutathione.
Kind of the
Yeah.
standard stuff. We have different formulas. If it's a viral issue, let's say, and I want to do an antiviral thing, I might throw lysine in there. I might use
Nice.
biotin for the skin and hair. So there's like little like tweaks that we use.
But I guess maybe going high level categorically, you do think that obviously this is something that people who have suppressed immune systems, amongst other things, maybe a tough time with being able to absorb things or tolerate things through the GI, that the IVs are at least something to
Yeah, and
consider.
I think the way I think about it is that yes, ideally you would get everything from your food and your diet. And then second best is you supplement, right? But a lot of patients have issues with supplements. It could be excipients, it could be they have trouble swallowing. So yeah, so IV, you can get some stuff that way. Some things you can get by injection, like vitamin D injections are really great for patients who can't get their vitamin D up, they're not absorbing it, or they can't tolerate the commercially available vitamin Ds. So they're like these nice tools, but generally the goal is always to get the patient doing well on their own and not relying on the IVs. By far, the
Sure.
ozone is
Sure.
is for me my favorite. I personally love how I feel after ozone.
Yeah.
So
Well, it's funny you say that because Kevin Wallace, he's a naturopath, and I mentioned him before we started the recording. He's super into peptides, IVs, a lot of the things. And he was telling me that ozone is the one thing that he's felt has moved the needle for him the most. And I've been thinking about going to do ozone
oh,
here tomorrow. And given your endorsement, also, I might make sure to get that done because the second clinician who I respect, who has access to a
right.
lot of tools, and still endorses ozone as one of the more powerful. That's cool. What about methylene blue? This is something that I
Yeah.
recently did some experimentation with, and it's purported to be an antibiofilm. I'm assuming there's probably some in vitro data,
Mhm.
at least mechanistically. I have to say, cognitively, for me, I felt fantastic on methylene blue, and I know it's also purported to help with mitochondrial
Exactly.
function, and so that may not be surprising. You're using
Yeah.
methylene blue orally,
Yeah.
IV, both, and I'm assuming you're hitting a pretty decent dose for the antibiofilm. I know Marty Ross recommends 50 milligrams up to two
Yeah.
times per day.
Sometimes
What are you
more.
doing? What are you noticing?
Because it has, the studies show that it has Bartonella activity, anti-Bartonella, particularly the stationary phase of Bartonella. So it's a tool for killing, for, yeah, like you said, biofilm for mitochondria. You probably used, do you recall what your dosing? Did you use like 5, 10, 15 milligrams?
I had
Okay.
tablets that were 15 per tablet. I started with a Troscript, actually, if you can see
Oh,
that
oh,
my tongue is blue.
love
So
it.
the Troscript, shout out to Dr. Scott Scher, who gave me some samples. I think this is more so for if you're trying to get a little bit of
Right.
a cognitive buzz, but you can't really go high when you're using the absorption through the tongue. You can get maybe 16 milligrams. But it's inconvenient, right? Having the blue
Yeah.
tongue is a little bit weird. So I used pills that were 15 milligrams and two of
Okay.
those a pop
Oh, okay.
twice per day. And yeah, I felt a nice benefit from them. I noticed when bedtime came, I was energetic all day. And then at 10:30, 11, I was just ready to go to bed. So I had a nice
Nice.
response to methylene blue.
Okay.
Although after about a week, I started getting some joint pain. And
Oh.
this hints at something that I'll just briefly touch on, which is I think I was over supplementing in trying to improve my health. I think I've had a little bit of an issue with Bartonella over maybe the past year. How this transpired was lots of
Mhm.
stress. And then I think I needed some antiviral and anti-Bartonella support. And I probably got over that pretty
Mhm.
quickly, given a quick response. But I said, well, let me do everything I can to get myself as healthy as possible. And I didn't stop using the supplements. I think I overtreated and I started reacting to things. And I think it's because I taxed my
Mm.
liver. So one of the things I've seen is response. And then I start having signs of liver toxicity, redness in the eyes, joint pain, at least as I've been able to tell. So a quick lesson, I don't want to take the floor too much away from you, Tanya, but there is such a thing as oversupplementation. And as much as I've said this on the podcast, I've also learned it myself, which is why in the clinic we try to be good about not just giving people handfuls of supplements. So methylene blue, good for a while, but I think and as I'm doing now, need to chill out with the stuff that I'm taking and be careful not to overtreat.
And I wonder, just to give you another perspective, if I may,
Please.
I wonder in some ways if you were actually opening up your biofilms. I mean, this is the biggest issue I think with infection, and I should have mentioned it even earlier, is that really like all these infections live in biofilms, and there's probably other infections and other things that are living in biofilms that we can't handle. So I think if you were breaking stuff down, or maybe even killing a little bit with the methylene blue, because the dosage you were getting to, right, if you were doing like 30 milligrams, 215s twice a day, so you were getting up to 60 milligrams, that's already the antimicrobial dosing, not just mitochondrial dosing. And I wonder if you were, two things, either stirring the pot and making things a little bit more like you're starting to kill, and then they were getting more activated. That's kind of one of the things that we see a lot, or whether you started breaking down biofilms and you couldn't handle what was being released from the biofilms. So if you pull back on that stuff, you'll feel a little bit better. Things will calm down. And that may be why, right? So that's just my perspective. And I don't doubt the liver was being taxed too. I'm sure there was a combination of things, but I wonder, and that's the challenge of using things like methylene blue. I'll do a much lower dosage if I want the cognitive stuff for patients. But as I start to go up in dosage, I have to make them aware that we're actually killing. And so I have to make sure that I'm also supporting them in other ways with the methylene blue. So generally, I might start somebody out again, like 5 milligrams or 10 milligrams for cognitive stuff. I might get them up to 15 milligrams, maybe once a day, if it's, again, cognitive. But then, 25 twice a day, 50 twice a day. I've gone higher than that for patients that we've done this Dapsone protocol, which is a protocol that Dr. Horowitz put together and published on. So a few patients that I've done the new Dapsone protocol in, we're up to like 300 milligrams of methylene blue twice a day.
Wow.
Which is a little. It's only a few days, but it's it's up there. But generally, if I'm going to use it not in that protocol, and I'm going to use it in a protocol where I'm using herbs, I'm going to make sure I want people on clove, oregano, cinnamon, maybe peppermint, because that's going to help support the biofilms, but it also has activity against stationary phase Bartonella. I'm going to combine it again with the methylene blue. Then I'm going to do, I might do other things to help support. Because what I've learned actually is that methylene blue, if you go too high alone, you are maybe starting to kill and the body's not ready for it.
Sure. And I was on Cryptopolis, and I'm going to butcher the pronunciation of this. Houtinia or Houtinia. Yeah, I mean, I'm still sorting some of this out, and I may actually check in with you, but the more I've reflected on this, I really didn't have much in the way of symptoms, and I think I was going a little bit overboard because I've seen this a few other times where I'll start to have similar reactions that plus a elevated bun. So I think maybe I've just been putting too much stuff through the system. But I also take your point, right? Which is if someone starts having a reaction, they come off the antimicrobials, they feel okay, but then they start to regress. That would be very demonstrative of someone who needed the antimicrobial therapy. So a learning, but we'll see. But so you are finding methylene blue then is something worthwhile to consider.
Yeah. I think it has its place. I think you have to screen. It does interact with certain medications. You have to be careful, particularly with SSRIs.
Also for the G6,
And G6PD.
and maybe to put this out there for people, the G6PD, that and high dose vitamin C, if you have a deficiency in this enzyme, it can be quite deleterious. So it's important, guys, don't go out and do either one of these without having a screening. And you can do that at LabCorp request. It's not hard to access that test.
Super easy. And you need to know that because methylene blue, for all the good stuff that it can do, can cause hemolysis and sort of like exploding red blood cells. And that can happen if you're a higher risk if you have G6PD deficiency. It can cause, even though it's a treatment for something called methemoglobinemia, it can cause methemoglobinemia also, which is that, your red blood cells have hemoglobin that carries oxygen. The red blood cells can start to produce this other compound called methemoglobin, which doesn't carry oxygen as well. So you get, low oxygen levels. So methylene blue at high dosages can do that, not typically the dosages you're talking about. So you have to be aware of side effects, and you have to be aware of the other drugs like SSRIs and other psych meds you have to be careful combining.
Right. I'm assuming that lumbrokinase is also something that you may like for
I do. I
biofilms?
use a lot of lumbrikinase, nattokinase. Those are probably my two favorite. Sometimes both together, depending on what I'm treating. I think from a biofilm perspective, I think they can be helpful. But again, a lot of our patients have a lot of like endothelial dysfunction and issues with microcirculation, right? So those compounds, basically systemic enzymes, can be helpful for that. And if I'm worried about their endothelial function, I'll put them on, like let's say lumbrokinase or nattokinase or both, because they do hit a little differently. I might combine that with diosmin, which is a compound that has some really interesting research supporting the effects on the endothelial layer, and maybe some of these other they're called glycocalyx supplements. So inside the endothelial layer of the vasculature, there's this layer, it's called the glycocalyx. And when that gets destroyed, that's what we know where arteries are more prone to getting cholesterol built up and things like that. So there are a bunch of products out there now
Right.
that are seaweed based that can help that. And so sometimes I'll do like lumbrikinase with a glycocalyx product. There are a few different ones out there. Endocalyx Pro with a diosmin product. If I'm thinking about the biofilms, I'm going to do lumbrikinase with nattokinase with, again, like clove, oregano, cinnamon, some kind of combo of those maybe, because those are really great also for biofilm.
Right. It's just amazing how much in the natural toolkit we have.
Love it. It just makes things easier. But again, sometimes natural is not enough, right? I'm the first one to say sometimes you need the drugs.
Sure. Yeah, I think we're both, nonpartisan in terms of the tools that we recommend. Okay, well, boy, Tania, I feel like I could probably pick your brain here for hours, but let me kind of give a question to bring us into transition. We've covered some of the naturals. I guess the long short is there's a lot of options for people. There's kind of a lot to this, but I guess we might be able to say it's also not too complicated if you listen to the person, if you study their system, and if you take this one step at a time. I'm not trying to discount it and say, oh, it's easy, but it's a problem. It's a problem we have to solve over time with some trial and error. What would you want people to know kind of high level as we come to a close in terms of they're listening to this, maybe they've bounced around from a few doctors and been told you have Lyme or you have a co-infection. Maybe they think that they do, but they're not sure. How would you direct them? What would you offer them?
Yeah, the challenge really is, they need to find somebody that they can work with, through this, right? And that's a challenge because, we're training more and more people out there, but there's still really a little bit of an empty space in this world of vector-borne infections, mast cell activation syndrome. But it's getting better. And so, I think patients have to, unfortunately, be their own advocate all the time now. And it's unfortunate, but it is the reality. Like you always have to look out for yourself. You know your body better than anybody else. If you know something's wrong, fight for yourself the best you can. And try to find people who you can work with who can, kind of work through all these different issues. And if they don't know, what you want is somebody that, even if they don't know, they may not be the expert in Bartonella, right? But they have to have an interest in learning. That's like the number one thing. That's how you know you've hit the right doctor or the right practitioner, is they want to learn. They don't have to be the smartest. They don't have to be, they don't have to be from Harvard, but they really have to have a a thirst for knowledge and for wanting to help you and other patients, right? As long as they have that, that's what I have. Like, I just want to learn. I learn, I teach myself every single day. I learn from my patients. I learn from my colleagues. I learn when I do my podcast. I learn, when I'm sitting in front of the patient. So, and then I come home and I learn some more. So if you can find somebody who has a passion for learning, there are many of us out there who are teaching, who are educating. So if they're interested in learning more to help you, then come find us, and figure out a way they can learn so they can help you, So I think that's just, one piece of advice. I think the other piece is really just to, I do think you have to look for testing. Like, you have to get the testing done. You have to figure out a way to really get the answers that you need, whether it's infection, whether it's mast cell activation, or whether it's mold, whether it's your immune system, whatever it is. Like, I really think that we talked about that. It's like, you don't need 1,000 tests, but you really do need to have some focused attempt at trying to understand what may be broken, why you may not be feeling great, because then you have a path to fix it.
I agree that we need more people with more training and more sort of, I guess, curious humility might be a way of describing it, which is why I've always appreciated chatting with you and your approach. And today's conversation was just fantastic. So, Tania, thank you again for taking the time
Thank
and
you for
speaking
having
with
me.
us.
This was so much fun.